Alright, let's do the hand, wrist, and elbow injuries. First, we have paronychia, which is the infection under the fingernail. It can happen as well as the toenail, but for this case instance, for this unit, we're doing it at the fingernail. This is an infection at the proximal lateral fingernail, usually from a result of bacteria. And as that bacteria goes into the skin through cuts in the cuticle and the nail foil. Now, for paronychia, there's two classifications of this. There's or actually three classifications, excuse me. There is the non-infectious, the acute/chronic, or the etiology. For non-infectious, it could be caused which is caused by non-infection. This is caused by contact with irritants, excessive moisture, or reaction of medications, which that will come up later for a different classifications. We have the concept of acute versus chronic, where acute lasts for less than 6 weeks, is painful, a purulent conditions, most frequently caused by a bacterial infection, especially by staph, or we have a chronic, which lasts longer and caused by overlying work conditions. In this case, usually caused by mechanical or chemical factors. Sometimes it affects etiology by like a fungal infection due to the Candida strain. Risk factors can include occupations such as dishwashing, swimming, like a professional swimmer, or any environment that you can work with high levels of moisture or dryness. While certain medications can be results or any similar suppression, or as in like a result of diabetes, HIV, and or malignancy. Or we have the etiology approach, where it classified by bacterial, viral, and fungi, and based on those three, it shows the most common result of it. So for bacterial is staph, for viral is the Herpes simplex complex, and as mentioned before, fungal is Candida, the Candida strain. For signs and symptoms, we have pain and swelling around the nail, so around here in the nail. Skin that's red and warm to touch, pus that builds up under the skin. So right here where my nail needs to skin, you will see a buildup of pus there, or a white and yellow abscess may form. So this test, in most cases, physical examination, like you will see the buildup of pus, redness, and swelling, the buildup of swelling inside the fingernail. For most cases, if it's by infectious, a sample of the infection of the buildup in the finger will be sent off to a lab, and it can be determined if it's bacterial, fungal, or viral. For treatment, for most cases, drainage is a circle option, where it drains the buildup of fluid out the finger. Usually, iodine is used to sanitize or sterilize, and then a small cut is inserted here, and it drains out the fluid. Which, fun fact, I tend to bite my fingernails, and ironically, this actually happened to me, so I had to go to the hospital, get iodine around my finger, and they were to drain the buildup of fluid out my finger. Other non-surgical ways, if it's chronic, make sure to dry your hands as possible. Change type of moisturizer or any type of skincare products that may cause the injury, or wearing gloves when washing dishes or working in environments where your hands are mostly exposed to dryness or moisture. Another way you can be soaking your hand in water or antiseptic solutions, and over-the-counter medications as well can treat. That will also depend on if it's viral, fungal, or bacterial. So what will this look like? As I mentioned before, the top fingernail of I believe that's the thumb, is not affected. There's no buildup of pus or redness. While you see at the bottom, you see here the buildup of pus here, and the redness in the fingernail. Next injury is olecranon bursitis, as we mentioned before, as anywhere in the joint. Bursitis, also known olecranon bursitis, also known as serous elbow. This is inflammation in the olecranon bursa sac, usually caused by trauma, prolonged pressure on the elbow, or infection or septic. So for trauma, as it's getting hit in the olecranon process, prolonged pressure is in most what is also called student's elbow. Most students, when they're in lectures or in class, they will put their elbow against the desk or their table for long periods of time. Or infection, this could be a result of getting sick or any other like medical condition, or just could be a result of, speaking of medical conditions, this could be a result of rheumatoid arthritis or gout. So for this case, signs and symptoms is swelling around the elbow, pain when moving from elbow flexion to extension since you're moving the olecranon back to its place. Discoloration on warmth, point tenders at the olecranon bursa sac over the olecranon itself. Special test is MRI to look at the bursa sac itself. It's soft tissue. Fluid testing, like I said before, with the previous injury of fluid, some doctor will drain some of the fluid, the affected fluid in the bursa sac, and send out to testing, see the result of gout or any type of septic infection. For treatment, you can also have drainage. That's for if it's infected, or in most cases, for non-infections cases, removing the bursa sac. And for non-surgical, we have medication in NSAIDs, elbow pads. So say if you're in sports or doing the common chores that requires you to be on your elbow, you have pads to protect it. Sometimes people will put a towel or a pillow under it. Changing activities, meaning doing more activity that doesn't require you to be on your elbow as much, or changing how you do perform exercise so where you have less pressure on the elbow, and corticosteroid injections. What does this look like? So, as any bursitis, you see here at the olecranon bursa sac. Here, that's the buildup of inflammation. That's the point. That's the redness. The point tearness there, and you look at the more bony image strain here. We have the olecranon and the bursa sac, and right there you will see the inflammation and point tearness and the redness and the swelling. Next, we have elbow OCDs. This OCD is it's a localized injury, and it's the subsequent separation of the articular cartilage, the subchondral bone of the capitellum, mostly seen in gymnasts and pitchers, and it's usually caused by the repetitive compression type of injury. And a result of elbow OCD is Pander disease, or osteochondritis of the capitellum, which mimics the elbow OCD, but it's more a difference of it's more of a benign injury, and it tires the entire capitellum. And this injury has 3 types. The type 1 is the cartilage is intact and bony stability may or may not be present. Type 2 is where the cartilage fracture with bony collapse or displacement. And type 3 is loose bite that's present inside the joint. So for signs and symptoms, we have swelling, stiffness, loss of extension, and feeling a lot catching or grinding. Special test would be X-ray, and for this case, also MRI. For this case, it will look for the size, the extent of edema, and cartilage status. And for treatment, it's a procedure which, example here, we have the OCD injury here. Then the injured area is removed to make a space for the graft. Then the healthy tissue replaces the OCD injury. Or for non-surgical, we have immobilization. And what it looks like, so again, here we have the capitellum and that little bony indentation here where it is, looks like it actually the second stage of the surgery is where the OCD injury is here. So this image shows the surgical aspect of where the OCD injury is and how to replace it as well as the previous picture before. Next, we have scaphoid fracture. As the name states, this is where the scaphoid bone is fractured. And for this, the scaphoid bone is the most fractured of the carpal bones. And usually the MOI of this is FUSH. But the result of a scaphoid injury is Purser's disease, which is a condition that caused by avascular necrosis of the scaphoid, which can lead to progressive wrist pain. Will show how the fracture happens, so the X-ray confirm each three of the classifications of what type of fracture stability is, what type the fractional line is, and the pattern of the fracture. Going back for special tests, we have the classic fracture test, the tap and tuning fork test. For treatment, for non-surgical, we have cast embolization. But for surgical, we have percussion screw fixation or open reduction internal fixation. And what does it look like? So as you see here, that's the fractured scaphoid here. That's the scaphoid itself, and that little line, that cross line here is the fracture. Next, we have lateral epicondylitis of the elbow or tennis elbow. Tennis elbow is an often overused injury, primarily due to a repetitive strain from the tasks or activities that involve loaded or repetitive gripping and or wrist extension. And the reason why it is called tennis elbow is due to being a common in tennis players, but it can also be found in sports that require repetitive wrist extension, radial deviation, and or forearm supination. And it can also be precipitated by poor mechanics or techniques or improper equipment, such as if you're a junior tennis player and using adult rackets, probably you're not used to using that adult rackets, so you're putting more force into your swings. And poor mechanics techniques is basically what the name says, that if you're a tennis player and you're not using proper tennis techniques, you're probably putting more load onto that lateral epicondyle and their extensor tendons. So for signs and symptoms, again, we have inflammation, because it's inflammation, stiffness, swelling, weakening grip strength, pain on the lateral elbow. For some people, that pain is described as a sharp or burning sensation, and pain will worsen when twisting or bending your arm. Special test is a tennis elbow test. Treatment, you can do surgical, which is extensor carpi radialis brevis debridement, sometimes longest, but most commonly is brevis. And this is following an incision over the lateral epicondyle. The tissue along the muscle tendon origin of the extensor carpi radialis brevis is removed. For non-surgical, we have RICE, OTCs, which is over-the-counter medications, in this case NSAIDs, and physical therapy. Again, what will this look like? So we have a picture of the lateral epicondyle, the extensor tendon muscle here itself. So at the red part here, that's the inflammation at the lateral epicondyle. So if you were suspecting somebody who have tennis elbow, when you do the tennis elbow test, we put your finger at the lateral epicondyle as you do the test. The point tendons will be at where you put your thumb at, which is the lateral epicondyle. So our next injury we have is Niebuck's disease. This is an avascular necrosis of the lunate bone. It can cause either by biomechanical factors or anatomic factors. For biomechanical factors is ulnar negative variance, which leads to increased radial lunate contact stress, a decrease in lateral inclination, which is where the lunate is positioned. Repetitive trauma. So repetitive hitting force on the lunate. Or the anatomic factor is the geometry of the lunate, as in the shape of the lunate. Vascular supply lunate, which is the patterns of arterial blood supply, have differential indicators of avascular necrosis, a direction of venous overflow leading to increased interosseous pressure, or blood supply to the capitate is also reported mainly to avascular necrosis. And this has 5 classifications: stage 1, 2, and 3A, 3B, and stage 4. And each stage of this determines what you do for treatment. So for stage 1, there's no visible change on the X-ray. May see it in the MRI. Stage 2 is sclerosis of the lunate. Stage 3A is lunate collapse, no scaphoid rotation. Stage 3B, the lunate collapses, fixed scaphoid rotation. And stage 4 is degenerative adjacent in the intercarpal joints. And if we go to, which we will go to treatment in the next slide. So let's first talk about signs and symptoms. We have dorsal wrist pain, swelling, limited range of motion, decreased grip strength, point tension on the lunate bone, and creaking, crackling, or crepitus. Supposed test is X-ray or MRI for depending on what stage it is. But as I mentioned before, each stage has a certain treatment wise. So we're going here. Stage 1 is emulation with NSAIDs medications. Stage 2 is joint leveling procedures or STT fusion, ulnar nerve patients, dorsal radius cord decompression. Stage 3 will be same as stage 3A, will be same as stage 2. Stage 3B is proximal row carpentry, STT fusion or SC fusion. Stage 4 is wrist fixation, proximal row carpentry, eliminate intercarpal fusion. Again, this is how it looks like. In this case, it shows the displacement of the bones of the scaphoid bone and the lunate bone. So we see a dense verticalized lunate. So the lunate is still not displaced yet, but it still is range area. But here, after the events in stages, the scaphoid lunate bone is now widened. And this is my works cited page.